Hi, my name is Ted Sakai. The title of my talk is Physics Monitoring and Anesthesia Delivery Devices, which unfortunately one of the least entertaining topic to you, but please bear with me for the coming 90 minutes. And then I do not have any conflict of interest to report to you. So these are the lists of the topics I'm going to cover, starting from A, mechanics, B, flow velocity, and then to the G, next slide, monitoring method, and then I will end the talk at M, electrical, fire and explosion hazard, and also basic electronics. So first of all, mechanics. I'm going to talk about the pressure measurement of gases and liquid. And the second, transducers, regulators, medical gas cylinders. So pressure measurement of gases. As you know, we have a portable cylinder, which is called E cylinder. And then we have a hospital type largest cylinder called H cylinder. And then normally we use 4 kinds of gases, oxygen, nitrogen, nitrous oxide, and also air. And then let's focus on the O2 cylinder. And then O2, oxygen has a critical temperature, minus 119 Celsius. I'm going to explain about what the critical temperature is. And then anyway, in the E cylinder, if it's full, we have 2,000 psig per square inch pressure, which contains 660 liters of oxygen. So if the pressure indicated 1,000 psig, it means that you have 330 liters of oxygen inside the tank. So if you run 3 liters per minute of oxygen with the 1,000 psig, it can last 110 minutes. It is similar in air and also nitrogen. Now, nitrous oxide is different. This has a higher critical temperature, which is 36.5 Celsius. Therefore, in an E-cylinder mixture of the gas and liquid, and then maintain constant pressure of 745 psig, as long as there is liquid nitrous oxide inside. So there is no way to determine how much residual nitrous oxide you have based on the pressure gauge itself. Therefore, in order to determine how much residual nitrous oxide you have, and then you have to weigh the cylinder. So transducers. A transducer is a device that converts one form of energy to another form of energy. There are so many kinds of transducers. For example, in the medical field, we have electrochemical transducers, including pH probes, electrogalvanic fuel cell, hydrogen sensor, and then we have electromechanical transducers, which we use a airflow sensor. And also, we have the electroacoustic transducer, which is called hydrophone or sonar transponder or ultrasonic transceiver. Regulators. Mechanism to reduce the pressure of cylinder or pipeline in a breathing machine in order to protect the patient from viral trauma. In a pipeline or cylinder, oxygen pressure is 1,800 psig to 2,200 psig. It's too high. Therefore, first a safety measure and then regulator reduce the oxygen pressure to 45 to 47 psig. And then to the ventilator, the second regulator further reduced the oxygen pressure to 18 to 20 psig. I'm going to talk a little bit later. Some machine has a second regulation to drop the pressure to 20 for the oxygen and then 38 pSig to nitrous oxide. Anyway, so the patient is protected with the two-stage pressure regulation. As I mentioned before, medical gas cylinders has E and also H cylinders. And then for oxygen, nitrogen, nitrous oxide, and the air, we have a color coding. In United States, oxygen is green, and also air is yellow, nitrous oxide is blue, and nitrogen is black. For the international standard, oxygen is white, and also air, which contains the oxygen and also nitrogen, coded with white and black. So let's talk about the flow velocity. I'm going to talk about viscosity and density using laminar and turbulent flows. And then I'm talking about a flow meter, which is called a rotameter. And also I'm going to talk about the principle of Doppler ultrasound. So viscosity and density, what are they? Viscosity is a measure of fluids resistant to flow, and density is defined as object mass per unit volume. Why this is important? Well, because we have two kinds of flows. One is a laminar flow and a turbulent flow. So not all fluid particles travel at the same velocity within the pipe. The shape of the velocity curve depends upon whether the flow is laminar or turbulent. For example, in the left side, laminar flow, which is a parabolic shape, where the center of the tube is the fastest flow, and then the flow speed is reduced when the materials are close to the wall. On the other hand, in the turbulent flow, as you can see on the right side, and then this is the kind of irregular, totally irregular, without any pattern at all. So that's called a turbulent flow. So first of all, laminar flow. So layer of the water, for example, flow over one another at different speeds with virtually no mixing between layers. That's the kind of inside the garden hose when you water the garden. The flow is characteristic of viscous fluid or the thick fluid, like water. Therefore, the viscosity of the fluid plays a significant part. So laminar flow follows the Poiseuille law. As you can see in the bottom, the rate of the flow is proportional to the fourth power of the pipe's radius, which is r. Therefore, when you see the increase of the radius of the pipe by 2 times, then you will get 16 times more flow rate. And then flow rate is Q is also dependent upon the fluid viscosity, pipe length, and also pressure difference between the end of the pipe. So the turbulent flow, as I mentioned before, it's an irregular movement of the particles of the fluid. The particles travel in irregular pattern without any observable pattern or no definitive layers. The flow is one in which density of the fluid plays a significant part. So you can produce the turbulent flow when you squeeze the Warden garden hose. So I'm moving on to the rotameter. So as you can see, this rotameter, you see this one, and always when you give the anesthetic. So this is the device measures the flow rate of liquid or gas in a closed tube. This rotameter has a calculation by the specific agent it used. As the flow rate depends on the gas's viscosity at low laminar flow, as I mentioned before, and also its density at higher turbulent flow. So rotameter rotates constantly inside the tube. This is because in order not to keep the flow not keep it in the in order to keep it in the center and minimize the fraction between the wall. So I'm going to discuss about the principle of Doppler ultrasound. So ultrasound image of the flow are essentially obtained from measurements of movement. And then in ultrasound scanner, a series of pulses is transmitted to detect the movement of blood or other structures. Anyway, echo from stationary tissue are returned at the same from the pulse to a pulse. However, the echo from moving scatterers, for example, the blood or red blood cell, exhibit slightly different in time for the signal to be returned to the receiver. These differences can be measured as a direct time difference, or more usually in terms of the phase shift from which the Doppler frequency is obtained. There are processes to reduce either a color flow display or Doppler sonogram. Let me explain a little more. As I can show you here, you can face the red blood cell flow through one of the vessels, and then you use the transducer and then detect the ultrasound image. Anyway, so as you can see here, T1 is the baseline image you get from the red blood cell, and T2 is the movement of the red blood cell. And then you can see the difference between the T1 and T2 with the account of the angle, and then you can calculate the speed or velocity of the red blood cell. This is a more closest schematical explanation about the Doppler. So let me move on to the next topic, properties of liquid gases and vapors. Diffusion of gases. So diffusion of the gases influenced by the following characteristics. One is that respiratory membrane thickness, diffusion coefficient, surface area, partial pressure difference. So the diffusion of the gas is improved with the thinner membrane, respiratory membrane, and also wider surface area and increased partial pressure difference. So let me explain a little bit more about the diffusion coefficient. Diffusion coefficient is a measure of how easily a gas will diffuse through a liquid or tissue. So for example, if the diffusion coefficient of oxygen is assigned a value of 1, then carbon dioxide is a higher diffusion coefficient, which is 20 times more than oxygen. Therefore, the number is assigned as 20. Solubility coefficient is the similar concept. This is the amount of gas that dissolved in a liquid is proportional to the partial pressure of the gas over the liquid. That's called Henry's law. Therefore, concentration of the dissolved gas can be calculated with the pressure or atmospheres times solubility coefficient. So at 37 degrees Celsius, solubility coefficient of the major gases are follows. Oxygen 0.024, carbon dioxide 0.57, and then nitrogen 0.012. As I mentioned before, there is 20 times more higher solubility coefficient of the carbon dioxide over the oxygen. Switching the gear, I'm talking about the humidity. We have relative humidity. What that means? The relative humidity is the ratio of the actual mass of water present in a volume of gas to the maximum amount of gas possible at a particular temperature. For example, the weight of the water in 1 liter of gas, and then you may have the 100% relative humidity or 50% relative humidity. Now, absolute humidity is the exact amount of weight of the water in 1 liter of gas, and described as milligram per liter. For example, at 37 Celsius, if the relative humidity is 100%, the absolute humidity is 44 milligram per liter, which means that you have 44 milligram of water inside the 1 liter of the gas. Now, it's related to temperature. So the temperature reduced to 21 Celsius, and then 100 relative humidity at that temperature, you have absolute humidity of 18 milligram per liter. Now, critical temperature. Critical temperature is the temperature below which the gas can be liquefied with pressure. For example, oxygen critical temperature is minus 119 Celsius. So if the temperature is lower than that, you can liquefy with the oxygen with the pressure. And then liquid storage tank in a hospital O2 storage system has the liquid oxygen. And therefore, those liquid oxygen tank is reduce the temperature below minus 119 degrees Celsius. Which means that if the temperature is higher than a critical temperature of the certain gas, no matter how much pressure you applied for the gas, you cannot liquefy that gas. So what are the critical temperatures of each main gases? As you can see here, the oxygen has a critical temperature is minus 119 Celsius, and then carbon dioxide has a 31.2, and then O2 water has the 374 Celsius, which means the temperature higher than 374 Celsius, you cannot liquefy oxygen. Now, critical pressure. The pressure, that means the critical pressure is the pressure required to liquefy the gas at its critical temperature. So it totally depends on the substance. As you can see, oxygen has 49.7 atom required to liquefy it at the critical temperature, minus 119 degrees Celsius. So I'm moving on to the gas laws. As you know, we have ideal gas laws. I explained that later. The equation is RV equal nRT, where P is the pressure atom, V is the volume of the gas liter, N is the number of molecules in mole, and R is gas constant, as you can see here, and T is the temperature in Kelvin. Now, we have 4 major gas laws: Guy-Lussac's law, Boyle's law, Charles' law, Avogadro's law. For example, Guy-Lussac's law is the relationship between the pressure and also temperature. So pressure halves and the temperature halves. Boyle's law is a relationship between pressure and volume. So if the pressure is increased twice more than the baseline, volume should decrease 1/2. Charles' law is a relationship between the volume and also temperature. And then those 3 laws, Guy-Lussac's, Boyle's, and then Charles' law, related to the pressure, volume, and or temperature. Now, only one law dealing with the number of molecules is Avogadro's law. So when you have to remember one of them, I would recommend you to remember Avogadro's law, which deals with the number of molecules among the gas laws. So the gas law, according to the gas law, gas mixture is just additive of the number of molecules and the pressure. For example, you have the gas 1, which has the P1 pressure and N1 molecular number, and then you have the second gas with the P2 and the N2 with the pressure and the molecule size. If you mix these together, you have the pressure of exactly the additive of the P1 and the P2, and the molecular size of just additive N1 and N2. So I switched the gear and the vaporizers. I'm going to discuss about the vapor pressure and the vaporizer types. So vapor pressure, what is this? The vapor pressure is a liquid. Vapor pressure of the liquid is the equilibrium pressure of the vapor above its liquid or solid. In other words, as you can see in the diagram here, the pressure of the vapor resulting from evaporation of the liquid or solid above a sample of the liquid or solid in a closed container. So you can use this concept as a calculation of an anesthetic concentration. Now, you know that Halton vapor pressure at 20 degrees Celsius is 243 millimeter mercury, and then you know that 1 atmospheric pressure is 760 millimeter mercury. In copper kettle vaporizer, 1 atmospheric pressure, then when you give the 100 cc of oxygen through that copper kettle, you can get 150 cc of halogen and the oxygen mixture. In that mixture, you have 32% halogen vapor. Why? Because you can calculate like this way, 243, which is the vapor pressure of the halogen, divided by 760, which is the 1 atmospheric pressure. So that's the calculation of the halogen vapors concentration inside the copper kettle vapor gas. Now, when you want to deliver 100% halogen, how much oxygen you have to add? This is the easy calculation. 32 times 150 milliliter divided by 1.5. That will provide you an X, which is the required oxygen gas volume required to generate 1% halogen vapor, which is the 3,200 milliliter. So as I mentioned, copper kettle, as you can see in the right side of the top, and then which is the older type of vaporizer where you may not see it in your practice. All you see as the current practice, variable bypass vaporizer, as you can see in the right side down. And then it's agent specific and then adjusted per agent. So if you switch the agent from one to the other vaporizer, what would happen? For example, if you mistakenly provide the halogen in the effluent vaporizer, this is what happened, the overdose. Why? Because the halogen has higher vapor pressure, which is 243 millimeter mercury, compared to effluent's vapor pressure, which is 173 millimeter mercury. Therefore, in the same adjusted dose of the effluent vaporizer, actually you provide the 40% greater amount of halogen vapor will be delivered. So, copper kettle has the potentially safety issue, which pretty much solved by the variable bypass vaporizer. Let me explain about the potential issues. One is that total gas flow drop. So this is the cause the potentially the overdosing because of the low flow through the copper kettle. But variable bypass vaporizer provide the wider range of stable gas, which means that as low as 250 millimeter per minute to as high as 15 liter per minute. So variable bypass vaporizer is more safer compared to a copper kettle. Excessive tilting. If you tilt the vaporizer, then you may see the high concentration of the anesthetic gas, which may or may not be prevented by the variable bypass vaporizer even. And then a pumping effect. This is the effect you can see about the fluctuation of the downstream pressure with positive pressure ventilation, which leads to transient reversal of the flow. Therefore, it may cause unexpected change of the concentration of the vapor pressure. So in order to prevent that from happening, we have the one-way check valve in the copper kettle and also variable bypass vaporizer. And the temperature change, copper kettle has not good adjustment with the temperature change, but nowadays variable bypass vaporizer will adjust the dosage per the temperature change. So I'm going to talk about uptake and distribution of the inhalation agents. So first, three definitions. Fi stands for inspired gas concentration, and Fa stands for alveolar gas concentration. And then F small a is represent arterial gas concentration. Now, important things to remember is that the brain partial pressure is equivalent to F capital A, which is alveolar gas concentration. Now, the determinants of the alveolar gas concentration, inspiratory gas concentration, and arterial gas concentration are different. For example, inspiratory gas concentration depends on fresh gas flow rate. Higher the gas flow rate, and then you can achieve the target inspiratory gas concentration. And also, it related to breathing circuit volume and also circuit absorption. And the alveolar gas concentration is determined by the uptake of the gas. Uptake means that a removal of the gas from the alveolar space to the blood. And then also it reflects with the ventilation. And also it determined by the concentration effect and a second gas effect, which I'm going to explain to you later. Arterial gas concentration is dependent on the ventilation and perfusion mismatch, which means that if the gas shunted from the ventilating alveolar space, then there is no interaction, absorption of the gas into the arterial blood. So the factors influence uptake of anesthetic gas, uptake from the alveolar space to the blood, is the three factors. One is solubility in the blood and alveolar blood flow, and a partial pressure difference between alveolar gas and a pulmonary capillary flow, capillary blood. So the concept of partition coefficient is important in that regard. This is the partitioning of the anesthetic gas between the two phases of equilibrium, in this case, the alveolar space and also blood. So we use the term blood gas partition coefficient quite often. That reflects the blood solubility, actually. And then the higher the blood gas partition coefficient, the higher the blood solubility of the one gas. So when you see that blood gas partition coefficient of the various kind of gas, you can see desflurane as the lowest in number, and then highest in methoxyfurane, which is 12, which means that desflurane has the lowest blood solubility compared to the other agent. Especially methoxyfurane is notorious with the higher blood solubility. Now, alveolar blood flow and uptake, and then alveolar blood flow, which is reflected with the cardiac output in the absence of pulmonary shunting. Therefore, low output status means that low uptake of the gas from alveolar space to the blood space. So, which means that in a low cardiac output status, the low output of the gas, and then increased rate of rise of alveolar gas pressure and also inspiratory gas pressure, and then which means that rapid induction of the patient. So that's a kind of cause the potential of the overdosage. That's the reason you got to be very careful about the anesthesia for the trauma patient victim or low cardiac output patient. In theory, if the flow is stopped, and then anesthetic uptake is becomes zero. So concentration effect. This is the increasing the inspired concentration Fi. Not only increases the alveolar concentration Fa, but also increase the rate of rise, which exhibited Fa divided by Fi. I will explain that more. That concentration effect is due to the two phenomena. One is a concentrating effect, and the other is augmented inflow effect. A little bit complicated, but let me explain. So, when you provide the 20% of the gas, which happen to have the 50% uptake in the blood, and then when you just infuse that in the space, the 80% of the other gas is coming, but given that 50% intake, and then gas percentage will decrease from 20 to 10. Therefore, our total gas volume is 10 plus 80. Now it's divided by, that's the kind of total volume, and then 10% of the gas divided by 90, which provides the concentration of the 11%. When you increase the concentration of the gas from 20 to 80%, what will happen? The same 50% uptake, then alveolar gas pressure become the 67%. Why? Because 80% of the gas and then 50% of them is absorbed into the water. That leaves the 40% of equivalent volume inside. So the 40% of the gas divided by 40 plus the other gas, 20% equivalent volume, and that is lead to 67% of the concentration. Now, when you compare these two, the inspiratory concentration increased fourfold, 20 to 80%. However, the alveolar side, it increased sixfold, from 11% to 67%. So that's the one factor that causes the concentration effect. The second factor, which contribute to the concentration effect, is augmented inflow effect. For example, nitrous oxide is about 20 times more soluble than nitrogen. And then, so that's the reason the volume of nitrous oxide entering the pulmonary capillary is greater than nitrogen leaving the blood and entering the alveolus. And therefore, the alveolar volume decreases, and then Fa of the nitrous oxide increases. So we have a second gas effect. This is the concentration effect on one gas upon the other gas. What that means is that if I have a high concentration of nitrous oxide, will augment not only its own rate of rise, Fa divided by F1, Fi, but that of the concurrent administration of the inhalation agent. For example, when you use the sevoflurane along with the nitrous oxide. However, this phenomena is not significant in clinical practice. So diffusion hypoxia is a reverse of the second gas effect, which is the elimination of the poorly soluble gas, such as nitrous oxide, from the alveoli, may proceed at as great greater rate as its uptake. So if you run the nitrous oxide a long time for one patient, when you terminate the anesthesia, remove the breathing tube, and then provide the oxygen with the face mask, you may see that hypoxia. That because the adding as much as 1 liter per minute of nitrous oxide coming out from the blood to the alveolar space. So you got to be careful about the flow of the oxygen when you use the nitrous oxide at the end of the procedure. So we are talking about the nitrous oxide. What is this? This is a colorless, odorless gas that is used as anesthetic and analgesic. And the blood gas partition coefficient is 0.47, which is one of the lowest blood solubility. So which means that at equilibrium, 1 liter of blood contains 0.47 cc of the nitrous oxide. So when you use nitrous oxide for the various type of procedure, you have to be very careful about its effect of closed space, because nitrous oxide will accumulate in a closed space during or at the end of the procedure. That may cause pneumothorax and pneumocephalus. And also when you use the nitrous oxide for the ENT surgery called the tympanoplasty, then that may dislodge the flap which established with the ENT surgeon. This is because of the higher blood solubility of the nitrous oxygen compared to nitrogen. Now, switch the gear. I'm talking about the item G, physics of anesthetic machine and breathing system. There are so many items. So, resistance of the anesthetic machine come from two sources. One is that you need directional valve and also CO2 absorber. That implication is important for especially in a pediatric population. So again, laminar and turbulent flow come into effect. As you might recall, the laminar flow on the left, which is the parabolic rate of flow inside the tube, and then compared to the turbulent flow on the right. So turbulent flow is a regular movement of particle of the fluid, and the particle will travel irregular pathway, no observable pattern, and then the turbulent flow depends on the density of the fluid or gas flow through the tube. Now, turbulent flow is important in terms of the ventilation. And then the airway itself, as you can see on the right side, resistance is relatively large. And then while the small airway provides more resistance than the single large airway, resistance to airflow depends on the number of the branches you have at the lung. Therefore, the large and then particularly the medium-sized airway, as you can see here, from the trachea, bronchus, that's the actually generate maximum resistance when you see the ventilation. So mechanical dead space. And in general, respiratory dead space is defined as a volume each breath that is inhaled but does not participate in the gas exchange. There are two kinds of dead spaces. One is an anatomical dead space, and the other is mechanical dead space. The mechanical dead space is important, and then which define the both inhalation and exhalation passes through the common pathway. Where is the location? Well, it's the portion of the endotracheal tube which extends out of the trachea from the mouth to the breathing circuit. That's important because from the trachea or down the mouth is considered to be the anatomical dead space portion. So, and then elbow with the breathing circuit, and also any connector used between the endotracheal tube and the breathing circuit, including the CO2 adapter apnea alarm adapters, and so on. And also, when you use the Y piece at the end of the Y circuit. So this is the mechanical data space. As I mentioned before, this is the Y connector starting and then ending at the incisor portion of the endotracheal tube. That's considered to be the mechanical data space. Now, dilution. Dilution of the vaporizer occurs in a variable bypass vaporizer, as you can see in the left, agent-specific, as I mentioned. And the diagram on the right side shows that a mechanism of the variable bypass vaporizer. So from the left side, the inflow gas is coming, and then with the dial increase, the portion of the inflow gas going into the vaporizer system, which carry the saturated vapored air is coming. And then which join in the bypassed inflow gas and then deliver to the patient. So you can regulate the amount of flow go through the vaporizer. In such a way, you can dose the gas concentration. Sometimes during the general anesthesia, you may see leaks. This is the sudden failure of the bellow to rise during the operation. And then disconnection alarm is triggered, and then you might think about the differential diagnosis. 3 reasons. One is that exhaustion of the hospital oxygen supply, which hopefully never happened. And then 2, failure to return to the flow control valves. And 3, gas leak. So leak, when you find the leak, what you should do? Well, you have to find the reason. And then what you have to do first is to do the resuscitation back to be applied and then continue the ventilation of the patient. While you are doing that, you should determine the site of the leak. Any disconnection of the breathing circuit, you can identify those with closing the APL valve, occluding Y piece, and activate the oxygen flash until the circuit reaches the pressure of 20 to 30 centimeter water. And then if you do that, and then you will still see the gradual decline of the pressure, that indicates the leakage inside the breathing circuit, including the breathing machine. So you have to remove the machine from the practice and then send that to the checkup. So gas mixture. As you can see here, the oxygen 100% gas has a viscosity of 1.11, density 1.11. Therefore, the rate of density and viscosity per viscosity is 1. If you mix with the nitrous oxide with the oxygen, viscosity decreased, but density increased. Therefore, density and then viscosity ratio is increased compared to the pure oxygen. So only helium has the decrease of density and viscosity ratio with the mixture of the oxygen, because with the mixture, viscosity is decreased, but density decreased farther. Humidity. Tracheal intubation and then high gas flow during the general anesthesia with the normal humidification system and exposure of the low airway to dry gases, that causes the dehydration of the mucosa. What are the complications of the dehydration of the mucosa? One is altered ciliary function, actually the decreased ciliary function. Therefore, inspiration of the secretion is very difficult to get rid of the secretion, which causes atelectasis, which causes the ventilation perfusion mismatch, which quite a grave consequence if you're taking care of the patient with underlying lung disease. In order to prevent that from happening, you have to provide the humidity. There are 2 ways to do it. One is passive humidifiers, and the other one is active humidifiers. So passive humidifiers is basically the mechanical nose, artificial nose. and then that's called the heat and moisture exchange unit. And then, however, the risk of using the artificial nose is increased rebreathing, especially significant with the pediatric population. And also excessive water saturation on the artificial nose may obstruct the breathing circuit. Additional benefit with the use of artificial nose is to protect the anesthesia machine from bacteria or viral contamination from the patient. Now, second way to provide the humidity is active humidifiers. There are 4 kinds of ways to do it. The pass over, which is passing the gas over the water chamber, and a wick through the saturated wick, the bubbling it through water, and a vapor phase, mixed it with the vaporized water. The top 3 methods are quite old, as you can imagine. So the heat for vaporization of the water is significant, which consume 560 calories per gram of water to be vaporized, so which account for 5 to 10% of the total intraoperative heat loss. So it is important to humidification and also the conservation of the heating, the temperature with the heating of the inspiratory gases, especially in the population, the pediatric patient, and also older patient with the underlying lung pathology, including cystic fibrosis. So, as you can see here, this is the component of the gas machine. So first, the common fresh gas inlet, the gas coming from the anesthesia machine for delivery, and then there's a unidirectional valve to prevent the return gas, and then which transferred into colligated breathing circuit, delivered to the patient, and return with the colligated breathing circuit, and then you have the expiratory unidirectional valve here. Then the gas is inflated into the reservoir bag, and then when you squeeze the reservoir bag, the gas is transferred into the canister for CO2 absorbent, and then return through the return tube, march into the additional fresh gas inlet. This is the direction of the flow from the breathing machine. Of course, you have the pressure regulation valve, APL valve. So important thing is that when you squeeze the bag, it's not directing the gas into the patient directly, but when you squeeze the reservoir bag, the gas, or expiratory gas, is returned to the canister of the CO2 absorber. That's the interesting things to think about. So we have a various kind of laryngeal mask airway, LMA, which is a part of the device called supraglottic airway device, rather. This is included as a difficult airway algorithm. And then important things to remember is this is not a definitive airway. Therefore, using LMA still incur the risk of aspiration compared to the endotracheal tube with a cuff. Now, we're moving on to the circle system. So we have non-circle system and also circle system. What are these differences? Non-circle system composed with the two systems, open system and a semi-open system. And then both does not have the valve or CO2 absorber. So open system is totally open, no valve, no tubing. While the semi-open system has some device attached, still there's no rebreathing, and then you have to provide high fresh gas flow in order to prevent the rebreathing from happening. And then usual anesthesia machine has a circle system. and then you have closed and the semi-closed. Semi-closed is the typical circuit system you use in a daily life, especially for adult population. So closed system is the totally closed, which means that you only provide the fresh gas inflow exactly equal to the patient uptake of the oxygen and also the other anesthetic, inhalation anesthetic, and then a complete rebreathing after carbon dioxide absorbed. So a CO2 absorber is important component of the circle system here. And also you have pop-off valve, which is closed entirety. So how you provide the open system, how you provide the anesthetic to the open system, you have insufflation way, which blowing the gas over the patient face, and then open drop way, which is the volatile anesthetic, is dripped onto the gauze covered mask applied to the patient face, which is used in the past when you have to use chloroform, and also draw over. You insufflate the gas of the, under the cover of the, some food or mask. And then, in general, in the principle, those open systems lack unidirectional valves and also CO2 absorption, as I mentioned before. The amount of rebreathing is highly dependent on the fresh gas flow in all. So you have to provide the higher fresh gas flow in order to prevent the rebreathing. And work of breathing is low in all systems. So this is the example of semi-open system. As you can see here, fresh gas flow is coming from the left, and then the patient inspires that fresh gas. And then when at the time of the expiration of the gas, there's a unidirectional valve, and then which allow the expiration gas to go to the right side without mixing of the fresh gas flow. Therefore, the system prevents the rebreathing, and then it requires high fresh gas flow. So circular system, as I mentioned, semi-closed system is used and generally for adults. Some rebreathing occur, but fresh gas flow and a pop-off setting and the intermediate values. And the closed system can be used for pediatric population. And it's important to have a CO2 absorber to eliminate carbon dioxide. And also anesthetic agent O2 should be added based on the intake of these agents into the body. The benefit is to conserve the heat and conserve humidity, and also it decreases the anesthetic pollution. And also it can provide you the earlier detection clue of the leaks and the metabolic changes. The risk of the closed system is hypoxia and the anesthetic overdose. So this is the typical circular system, as you can see here, from the fresh gas inlet flow coming from the inlet side here, and then provided through the inspiratory limb. Of course, you have to have a unidirectional inspiratory valve provided to the patient coming back in the unidirectional way. And then there's a unidirectional expiratory valve here. And then moving on to the bag, when you squeeze the bag, the gas return to the mixture, and then mixture with the fresh gas flow after go through the CO2 absorber. So Maplerson's classification of the known breathing circuit is kind of notorious for you and for everybody. There are 1, 2, 3, 4, 5, 6 kinds, and Mapleson SF, the last one, is added later. The most important part is that to remember that Mapleson E system. This is the typical TPs, what were formerly called Ayer's TPs or Bain circuit. You provide this system for a lot of patients in the PACU after the general anesthesia. And then if you add the bag for the ventilation, and then it will go to the mifepristone D. If that system has the pop-off valve on the end of the bag, that's called mifepristone F, which other name has the Jackson-Lees system. CO2 absorption system is very important, as we discussed in closed system. And then there are three kinds of limes you have. One is soda lime and a bala lime hydroxide lime, and also newer version of the CO2 absorption called AMSOB. AMSOB is containing calcium hydroxide and also calcium chloride. The general principle of the soda limes are as follows. Granular size smaller, the absorption increase, but also increase the resistance. In general, absorbent granules can absorb and the gases and later release significant amount of volatile gases, which cause the delayed emergence. So for example, soda lime reaction is as follows. And then you have a CO2, and then you have water inside the soda lime, which create the bicarbonate. And the bicarbonate is metabolized into the O2 and also heat, and then that's a fast reaction. And slow reaction create the calcium carbonate. And then hydroxide salt are irritant to skin and mucosa. And that's the reason you have to add a silica to increase the hardness of the soda lime and decrease the risk of the inhalation with sodium hydroxide dust. But still, the silica itself may be the irritant of the mucosa. And also soda lime need the water for reaction, as you can see in the top chemical reaction pathway. So the soda lime normally has a water content of 14 to 19%. If the soda lime is dried, the more likely it will absorb and degrade volatile anesthetic, which is relatively dangerous. I will explain that later. So barium lime hydroxide is a mixture of barium hydroxide, octahydrate, and calcium hydroxide. So good news of the bala lime is that it's sufficiently hard without adding the silica, and it also contains water into the structure. So compound A. As you may know, the sibulfulin undergoes alkene hydrolysis and produces compound A, which is a halogenated alkene. And then compound A is reported to have the renal damage in the rodent. However, good news is that not reported in the human and primate of that damage. In a high concentration, low flow, high absorber temperature, the prolonged exposure, dry absorbent, that causes the increase of the sibulfulin absorption into the soda lime and also degradation into the compound A. Therefore, when you use the sibulfulin, minimum fresh gas flow is recommended of 1 liter per minute, and also the duration and then should be limited with a maximum dosage of 2 Mach hours. AMSOB, by the way, and also lithium hydroxide do not produce compound A because there's no KOH or NaOH are contained in those absorbent. Now, the carbon monoxide can be produced by that degradation. So carbon monoxide can be formed when inhalation agent interact with desiccated absorbent, especially in a soda lime. Which agent has the highest potential? Desflurane. And then the potential are desflurane, amphoulin, isoflurane, and the sibulfulin is considered to be the less causative agent to produce carbon monoxide. Switch the gear here. The oxygen supply system, as you can see here, the oxygen coming from the O2 pipeline supply from the hospital, or sometimes you have to use the O2 cylinder supply, which attached to the anesthetic machine. And then high pressure is reduced to the 45 and 55 per square inch with the first regulator. And then go into the anesthetic machine, second stage O2 pressure regulator, further decrease the pressure to the 12 to 16 psi in order to prevent the patient from viral trauma. The important part is that if you use the oxygen flash valve, that will bypass this second stage O2 pressure regulator, and therefore the patient lung is under the influence of the higher oxygen pressure, which is 45 and 55 psi. And that's the reason every time you use the oxygen flash valve, you have to remember you might render the patient with the viral trauma. So this is the schematic diagram of the waste gas evacuation system. As you can see, there's an active vacuum form attached for the scavenging of the contaminated gas with the inhalation agent. Inhalation agent is not benign because it will produce fluoride, and then that will cause the toxicity. So even the OR environment is protected with this waste gas evacuation system. You have to remember that this vacuumed air contaminated with the inhalation agent is released from the hospital system, and then so the general public may exposed with the inhalation gas agent, which may cause the fluoride toxicity. So this is the additional example of the safety system from exposing the low concentration oxygen. So this proportioning device, as you can see here, which attached with the nitrous oxide and also oxygen together, that prevent the lower oxygen hypoxia of the patient. This is how it works. Every time you increase the dosage of the nitrous oxide in your anesthetic machine, you may notice that oxygen also increase in the flow. That because this proportional device connect the hub of the nitrous oxide and also oxygen. And therefore, you cannot provide the 100% nitrous oxide to the patient. Rotameter configuration of the oxygen, air, and the nitrous oxide also had the safety precaution. The A and B in the top is unsafe configuration. Why? If the oxygen on the left side or upper stream of the fresh gas flow, and then any of the leakage can cause the hypoxia of the patient through here or through here. In order to prevent that from happening, always oxygen is situated on the downstream of the fresh gas flow. That's the reason, even though there's a first and the second rotameter tube has any issue of the leakage, and then still the patient received the oxygen. In such a way, the patient is prevented from exposing the hypoxic gas. As we mentioned before, this is the flow arrangement of the gases. Every time the pressure of the O2 supply is decreased in a dangerous level, the recent anesthetic machine has a fail-safe valve system which terminate the nitrous oxide delivery in such a way that will prevent the hypoxic condition to the patient. Now I'm switching the gear again to explain about the monitoring method. First, nerve stimulators. You use the nerve stimulator and mainly for the evaluation of the neuromuscular blockade and also the peripheral nerve block procedures. How about EMG, electromyography? And then you can use that system to check the recurrent laryngeal nerve injury, especially during the thyroid surgery. This is how it works. As you can see in the left side down, there's the endotracheal tube, which equipped with the EMG sensor. So neural monitoring is being advocated for the rapid and reliable identification of the recurrent laryngeal nerve and for predicting the post-operative vocal cord mobility. So those devices checking the EMG constant fashion and then ENT surgeon can monitor the facial nerve, recurrent laryngeal nerve injury with the eliciting that electrical probe and the surgical field. And then if the recurrent laryngeal nerve is adjacent to the resection portion, and then a technician can detect EMG activity from that sensor attached to the endotracheal tube, and also warn the surgeon they are closer to the recurrent laryngeal nerve. How about the EMG? The electromyography can be used especially for the protection of the recurrent laryngeal nerve monitoring during the thyroid surgery. So you attach the sensor device, the endotracheal tube, and monitoring the vocal cord movement or EMG in the continuous fashion. Every time the ENT surgeon is adjacent to the recurrent laryngeal nerve during the dissection of the thyroid gland, the technician can warn the surgical team they are adjacent to the recurrent laryngeal nerve. That can be detected with the activity of the vocal cord through the electromyography. So spirometer. And then it's a little bit kind of complicated, but you have to remember there are 4 volumes and also 4 capacities combined together. So the volumes include the tidal volume here, and also residual volume here, and also inspiratory reserve volume, and also inspiratory reserve volume rather, and also expiratory reserve volume. And then you have 4 capacity. One is that total lung capacity here, and also the vital capacity combined with the inspiratory capacity, and then also expiratory reserve volume, and also the inspiratory capacity, which combine the inspiratory reserve volume and also tidal volume, and also functional residual capacity, which is a combination of the expiratory reserve volume and residual volume. So when you use the inspirometer, and this is the curve you can get, this is called flow volume loops. So starting point before you blow your air into the inspirometer is here in 0, portion 0, okay? And then at the maximum expiration, the flow is registered like this, and then reach the peak expiratory flow. And then after that, the volume is increased, but the flow is decreased in a steady fashion to reach the vital capacity. This is the maximum expiration. After that, you inspire the oxygen, and then like this, and then go back to the baseline. So it's important to remember this flow volume loop is the expression of the flow and the volume inside the spirometer, not your lung. Now, you have a civil scheme here, which is quite commonly tested in your exam. Let's go through each one. Number top A is the exhibition of the normal, the higher rapid increase of the flow and also the steady decrease of the flow of the expiratory phase, and then just a steady shape of the inspiration. Now, when you have the patient with the emphysema, which has the mid-airway disease, you will see the same rise but slightly decreased component of the flow. But most pronounced part is here, that decrease the flow speed of the mid-air portion, which represented by FEB 25 to FEF 75%. That's the kind of a typical decrease you may see for the emphysema patient. When you see the unilateral main stem bronchial obstruction for, let's say, the right side of the lung main stem is collapsed, and then you will see the same proportion, same figure, same shape, but the decrease in the all component. When you have the fixed upper airway obstruction, you will see the decrease of the expiration flow and also decrease of the inspiration flow. However, total volume itself is reserved. Then it's a little bit more complicated. If you have the variable extrathoracic upper airway obstruction, this is what you can see. So this is only affected for that inspiration part, because the intrathoracic pressure is negative. Therefore, the variable extrathoracic portion is more narrow. So that's the reason you will see the decreased flow of the inspiration. On the other hand, if you have a variable intrathoracic lesion, and then you may see the decrease of the expiration flow, and then while the preserved inspiration flow, because the variable intrathoracic obstruction can be worse with the positive pressure applied in the lung tissue at the time of expiration. When you see the restricted parenchymal lung disease, you can see that the whole portion is decreased, but most pronounced part is that initial speed of the expiratory flow is decreased. When you see the neuromuscular disease patient, ALS or others, you will see the global decrease of the all component volume and also flow-wise. You have two kinds of capnography. One is side stream capnographer, which is the usual adult type general anesthesia. And also you have the mainstream capnography, which sometimes applied for the pediatric population. So side arm capnography is a sensor located in the main unit, and then you have to get the sampling tube with the sampling flow of the gases, and then which the speed of which around 400 cc per minute. And then optimal gas flow is 50 to 200 cc per minute, which allows the monitoring of the non-intubated subject. This is usable for even the MAC patient, monitored anesthesia care patient. So mainstream capnography is directly inserted into the YPs, and then a lightweight infrared source and a sensor attached here actually measure the CO2 content, which eliminates the need of gas sampling like the side stream capnography. And then it's provide the CRISPR waveform, which reflect real time end-tidal CO2 in a patient airway. So temperature. The core thermal temperature is composed of highly perfused tissue whose temperature is uniform and then high compared with the rest of the body. This is measured by pulmonary arterial pressure, pulmonary artery, and distal esophagus, tympanic membrane, or nasopharynx. And then core temperature can be estimated with the other modality, including oral, actually, in bladder temperature. But to reflect the core temperature in bladder temperature, you have to have the steady urine formation. And the skin surface temperature are considerably lower than the core temperature, and including foreskin temperature, for example, is typically 2 degrees Celsius cooler than the core. Sometimes you measure rectal temperature, but during the cardiopulmonary bypass, that temperature lag behind those measured in the core sites. So that's the reason rectal temperature cannot be included for the core temperature. Rather, it should be called as intermediate temperature. So the pulse oximetry. This is a non-invasive method for monitoring a person's O2 saturation in the arterial blood. So you have a 2-wavelength light, which has 660 nanometer and also 960 nanometer. And then you can see that difference of absorbance of the oxyhemoglobin and deoxyhemoglobin in such a way that can provide the oxygen saturation of the arterial blood. And then the device has the function to excluding venous blood, skin, bone, muscle, fat, and nail polish. There are several limitations. One is that you cannot get the blood oxygen content information from the pulse oximetry, and sometimes it provides low readings for the hypoperfusion or incorrect sensor application, and the highly closed skin or movement, such as shivering. And then since the pulse oximetry only measures the percentage of bound hemoglobin, a falsely high or falsely low reading will occur when hemoglobin binds to something other than oxygen. For example, carbon monoxide causes the carboxyhemoglobin that has the same absorption feature of the oxyhemoglobin. Therefore, carboxyhemoglobin is considered has a higher reading and may occur, despite the patient actually being hypoxic. And on the other hand, methylglobin and methylhemoglobin has the equal absorption of the 96 nanometer and also 660 nanometer. Therefore, that will provide you the reading of 85. In order to prevent that from happening, nowadays, the newer device called the core oximetry is in practice. This device provides you the oxyhemoglobin and also deoxyhemoglobin, and also the carboxyhemoglobin, also methylhemoglobin dosage. So instrumentation, I'm going to cover those most pertinent portion only. So arterial blood gas sampling require a calibration and also a temperature correlation. So the error can occur at the time of the ABG measurement. One is that due to pre-analytic error, including air bubbles inside the tube, and also time delay, and then a blood clot, and a small sample size, which causes the excessive dilution due to anticoagulation material, and also calibration issue. In order to calibrate the measurement instrument, you have to do systemic standardization. You can use the 2-point calibration, which should be performed after 50 blood gas sample or every 8 hours, or 1-point calibration prior to each sample analysis. Now, gas concentration can be detected with the mass spectrometry. So in general principle, the mass spectrometry can identify the amount of ions using the magnetic field, and then you can see the differentiation based on the mass of the ions. You can check the amount of molecules using infrared absorption. For example, if you use the infrared absorption to detect the number of molecules of the carbon dioxide, the number increased, the absorption of the infrared increased, and that will be reflected with the amount of the molecules of the carbon dioxide. So pressure transducers. It's important to understand the concept of resonance. So resonance occurred when the driving force frequency coincide with the resonant frequency of the system. So the resonant frequency, or natural frequency, is the frequency at which the monitoring system itself resonates and amplifies the signal. To detect or perform the accurate measure of pressure, the catheter tubing transducer system, when you use the arterial line, must be capable of responding adequately to the highest frequency of the arterial waveform, which has the frequency between 16 to 234 Hz. So most transducers have frequency of several hundred Hz. Also important to understand the concept of damping in terms of the pressure transducer. So damping is caused by dissipation of the stored energy. So anything which takes energy out of the system results in a progressive diminution of the amplitude of oscillation, as you can see on the diagram here. So the underdamping causes the higher spiking of the arterial pressure. However, if you dump too much over damping, and then you can see the decrease of the systolic blood pressure and also elevates of diastolic blood pressure. Important part is that it doesn't matter, no matter what kind of damping condition, the mean arterial pressure is unaltered. So overdamping or damping can result from air bubble, blood clot, soft diaphragm, or soft tubing in your system. Unlike the invasive blood pressure monitoring, often major time you use non-invasive blood pressure. This is the kind of system, what portion you measure the systolic and diastolic pressure with the non-invasive blood pressure monitoring. So oscillation is changed in the first from the higher portion. That's the time you measure as the systolic blood pressure. And then the oscillation is highest at the mean arterial pressure. And then at the time immediately before that oscillation is flattened, that's called the diastolic pressure. Sometimes the trauma or the cardiac case, you would use the auto-transfusion device or rapid blood transfusion devices. Important part is that the system has the capability to warm up the blood in order to prevent the hypothermia for those massive blood transfusion. So warming device is not only applied for the blood warmers. We have a number of blood warming devices intraoperatively or perioperatively. One is forced air, a heat lump, insulation device, a warming blanket, water flow, and a second skin devices. Important to understand the three phases of the temperature decline if we do not use any of the temperature device. Phase 1 is redistribution. And then phase 2 is actual loss of energy from the body. And then when the time passes, that you will see the phase 3 where the core temperature plateaus. This is the condition where the generation of the heat in the body and also dissipation of the heat from the body to the environment is reach the equilibrium. So in order to prevent the phase 1 hypothermia, pre-warming, probably half an hour with the forced air device is important, which is applied for the colon surgery or plastic surgery sometimes. And then other methods are basically prevention of the decline of the phase 2. Ventilators. There are a number of concepts you have to understand. So flow generation and pressure generation. Ventilators are most commonly classified either of these. And then constant flow generators, which deliver constant inspiratory gas flow regardless of airway circuit pressure. On the other hand, if you set up the constant pressure, then that will happen, So which maintain airway pressure constant through inspiration and irrespective of inspiratory gas flow. And then gas flow eventually ceases when the airway pressure equals to the set inspiratory pressure. There are a number of ventilator modes. So IMV, intermittent mandatory ventilation, are as follows. For example, CMV, controlled mechanical ventilation. The ventilator cycle from expiration and inspiration at a fixed time interval, no matter what type of spontaneous breathing the patient may have. And then AC, assisted controlled ventilation, has a sensitivity control which allows selection of inspiration effort required, and a ventilation can be set for a fixed ventilation rate, or, this is the important part, each patient effort for sufficient magnitude will trigger the set vital tidal volume. IMV, intermittent mandatory ventilation, is the mode selected number of mechanical breath for fixed tidal volume is given to supplement spontaneous breathing. And this is good for weaning, and then but it incurs the risk of stacking, which is the potential of overinflation of the lung when IMV superimposed on the spontaneous breathing. SIMV is a synchronized intermittent mandatory ventilation, which is to prevent stacking. So proper synchronization is added to SIMV. So SIMV is better than a simple IMV. So pressure support augment tidal volume of spontaneous breathing to overcome any increase of inspiratory resistance. And pressure control is mandatory. Pressure support with mandatory rate and inspiratory time are selected. The risk of the pressure control, again, is that tidal volume is not guaranteed. Airway pressure release ventilation and the high frequency ventilation. So APRV is a high PEEP, 10 to 12 centimeter water, is used during which the patient is allowed to breathe spontaneously. Intermittently, the PEEP level decreases to help augment the elimination of the CO2. High frequency ventilation has several kinds. One is that HFPPV, high frequency positive pressure ventilation, which is the small convectile tidal volume at 60 to 120 per minute. HFJV, the high frequency jet ventilation, the pulsed jet of high pressure gas, 15 to 30 psig at 120 to 600 times per minute. And then most frequently used mode of the high frequency ventilation is high frequency oscillation. This is the to and fro gas movement in the airway at a rate of 180 to up to 3,000 per minute. It's important to allow the patient exhale in order to prevent the valvular trauma during the HFV. So this is the bi-level positive airway pressure, BiPAP. BiPAP is a low-pressure, electrically driven device intended for use of the ventilator support system for patients who have an intact respiratory drive. This is the home device you may use for the obstructive sleep patient. So alarm and safety features, you can see a lot of safety features with alarm system, and then I'm not get into this in detail. Instead, let me describe about the defibrillators. You have two waveforms, a monophasic and biphasic nowadays for defibrillators. And then there's an increased trend of the biphasic waveforms are in practice. The reason is that to provide the to and fro energy to the heart, that can achieve the defibrillation with the same degree of success with the monophasic machine with the decreased energy requirement, therefore less myocardial damage. AED is the layperson's usage of the defibrillator. This is the microprocessor-based device that are capable of EKG analysis and differentiation of shockable and unshockable rhythm. And some types of biphasic waveform is used. AEDs should be placed in any public place when 20,000 people or more pass every day. ICD is implantable cardioverter defibrillator, and you may heard that single chamber ICD, dual chamber ICD, biventricular device, but the ICD portion is the same, which deliver the cardioversion through that the catheter tip situated in the right ventricle. The dual chamber has the pacing mode of the right atrium, so that will allow the sequential right atrium or atrial to a ventricle. And a biventricular device has the additional pacing device situated to the left ventricle in such a way that will provide the biventricular defibrillation and stimulation. So final portion, electrical fire explosion hazard, basic electronics. So risk of electrocution can occur if you touch the high voltage machine and your body is set on the ground, and then the ground current is returned to the high voltage machine. In such a way, if there's a circuit formed, and then you may have the risk of electrocution. So body contact with two conductive material and a different voltage potentially may complete a circuit and result in electrical shock. And all electrical equipment has leakage current as a result of capacitative coupling, induction between internal electrical component or detective insulation. So current can flow as a result of capacitative coupling between two conductive bodies. So isolation of transformers is quite important in the OR room. So in order to cause, as I said, electrical shock, circuit should complete hot origin and a body and a ground wire to the machine. In order not to complete the circuit, the operating room power supply can be isolated from the ground by the isolation transformer. Even a grounded patient attached to the live wire, current will not flow through the patient since no circuit back to the secondary coil has been completed. The line isolation monitor measures the potential of the current flow from the isolated power supply to the ground. Once the alarm of the line isolation monitor goes off in your OR room, this means that you have existence of the single fault between power line and the ground. So when that happens, you should remove the last piece of equipment, and then that was unplugged, and then return to the repair. So we have the macro and micro current hazards. Microshock, as I mentioned before, that's the you create the hot circuit, and then you got the cardiac fibrillation, and then that can be in order to cause the macroshock, you need 100 milliampere. However, for the patient hazard, a microshock is more important. That can be caused as low as 100 microampere with the energy in order to cause the cardiac fibrillation. That can be transmitted with the cardiac pacing wire or invasive monitoring catheter. Even blood or normal saline can be the conductance to cause the microshock of the patient. Now, the United States and the government has the safety regulation through the National Fire Protection Association standard. In 2012, NFPA 99 has a regulation of the OR safety. That provision governs installation of and inspection, testing, maintenance, performance, and the safety practice of the all equipment you can use in the OR room or the hospital. Finally, as you know, this is the intraoperative fire triangle. In order to cause the fire, you need oxygen and also source or heat and also fuel. And then an important concept is the combustion. And the combustion is the chemical reaction that feeds the fire more heat and allows it to continue. For example, nitrous oxide you use is the combustant. Therefore, when the OR fire occurred, you have to stop the providing the nitrous oxide if you use it.